You read the bill. It's all the narrative of universal pharmacare. So it all looks good. Then, okay, how do they define pharmacare? Pharmacare is defined as a drug plan, any type of drug plan. Universal is defined in terms of as long as everybody is covered. I live in Quebec. In Quebec, we have mandatory private drug plans. So based on the definitions in the bill, then the Quebec system, which by the way is the most expensive system in all of Canada. So basically after the United States, the second place on earth where it is the most expensive per capita is Quebec. It's based on mandatory private drug plans, and that fits the definition of the bill.
Welcome to Perspectives, a Canadian journal of political economy and social democracy. I'm Clement Nokos, editor of Perspectives Journal and director of policy at the Broadbent Institute. Earlier this fall 2024, Bill C-64, an act respecting pharmacare, passed and received royal assent in Parliament. This new pharmacare legislation is touted as another major expansion of Canada's public health system, in addition to the Canadian Dental Care Plan, which started to get underway last year. The achievement of a pharmacare plan was also a condition of the Parliamentary Supply and Confidence Agreement, which was terminated earlier in September, as this major component of the agreement crossed the finish line. Starting with contraceptive medications and diabetes medicines, the new pharmacare plan aims to, quote, provide universal coverage of pharmaceutical products across Canada. While, in principle, universal drug coverage very much aligns with social democratic values, Professor Marc-André Gagnon of Carleton University's School of Public Policy and Administration argues that the bill leaves the back door open to privatization. In his article entitled Pharmacare Access to Medicines in Canada, Is Bill 64 a Step in the Right Direction?, which you can now find online and in print in the latest issue of the Perspectives Journal, he argues that because of the vague language of the bill and because of the unrelentless lobbying of commercial stakeholders, these first steps can very well end up even further entrenching the current inefficient, inequitable, and wasteful mishmash of drug plans that has characterized Canadian drug coverage since the 1960s. Marc-André Gagnon joins us now to chat about his new article in Perspectives Journal number 2. Marc-André, thank you for joining us on the Perspectives Journal podcast.
Well, thank you for having me, Clement.
And so, why is National Pharmacare a program that is so needed in Canada? Why did we expend so much political effort into creating this piece of legislation?
Well, Canada is a bit of an anomaly, basically. It's just every country with Medicare, with universal health care, basically they cover prescription drugs because it is considered to be an essential healthcare service. Every developed countries except Canada. Basically, we are the only country with universal healthcare that does not include prescription drugs as if it wasn't an essential healthcare service. And basically, the whole thing is designed in terms of benefits provided by employers to employees. Problem with that is we end up with still a lot of people in Canada not being able to access the drugs they need. So basically, year after year, we have some surveys on what we call cost-related non-adherence. So basically, people not filling prescriptions because of financial reasons, and it is 10% of Canadians, more or less. But the thing is, at the same time, if you compare Canada with other countries in terms of cost per capita in prescription drugs, we're the most expensive after the United States. So not only we pay way more per capita, but access to drugs is very problematic. Basically, the system is not working. We have a fragmented system. We have over 100 public drug plans in Canada, mostly covering seniors, people on social assistance for specific types of disease, for example. We do have some catastrophic drug coverage sometimes. We have more than 100,000 private drug plans as well. And the thing is, with this fragmented system, everybody is going in their direction. There's no common objectives, and we're navigating a complexity, and especially with very powerful drug companies that sometimes can impose very high prices. Well, if we do not develop the institutional capacity to protect our population, we end up with high prices, low access. This is exactly the case we have right now. And I would like to add something. When I was writing the paper, something I realized, I've been working on pharmacare for the last 15 years, more or less. And this is a very Canadian debate. Nobody else elsewhere discuss pharmacare. They discuss healthcare. It's just the fact that we're kind of putting aside pharmacare, making this something independent to the rest of healthcare. This is only in Canada we have this type of discussion, which is kind of weird.
Canada is so unique in this case, but we are also famous for our universal healthcare. It seems like we have universal healthcare. Others would argue that Canada, compared to the United States, our healthcare system is quote unquote universal. But with Pharmacare, you say no. How would you define universal pharmacare for Canada?
Keep in mind, as soon as you go to the hospital, as soon as you enter the hospital, basically all the drugs you'll be getting is part of the provincial health budget. So this is part of the hospital spending. As soon as you get out of any healthcare establishments, when you get a prescription for drugs and you go to the pharmacy, then this is a completely different system. This is not universal anymore. This is not public anymore. This is mostly private drug coverage we see everywhere. What would be universal pharmacare? Well, pharmacare is basically public drug coverage. And universal is having one system that covers everybody in the same way. So having a list of reimbursed drugs for the whole population based on cost efficiency. So a universal pharmacare system provides coverage for everyone in the same way through a public administration. So one thing about public administration, we often discuss, the problems of the price of drugs with the private system versus public. In the private system, what we don't take into account is, for example, the administration fees for private drug coverage. This is on average like 13%. When it comes to a public drug plan, administration fees is more like between 1 and 1.5%. So depending where you are. So let's just say that the public administration is absolutely necessary. Having the whole population being covered in the same way is super important. The thing is, you don't need a system that is the only system for the whole population. What we have right now on the tables, so basically in 2019, the Advisory Council for the Implementation of National Pharmacare with Eric Hoskins, they laid out a whole plan to implement universal pharmacare in Canada in a way that is very prudent, rational, that will encounter the least resistance, and that will be a win-win situation for everybody. And for them, it's just, we need a good public coverage for everybody. And then if an employer wants to add up additional complementary drugs for any reason, okay, they want to cover Ozempic for weight loss or thing, fantastic, you can do that. We're not restraining employers to offer complementary coverage, but we do provide the good basic coverage to the whole population in a system that is working well. In a system that is working well, it's not only you can negotiate lower prices, it's also about collecting all the data about the prescribing habits out there. What are people consuming for which condition? Because one of the big issues is sometimes the prescribing habits have way more to do with the marketing campaigns of drug company instead of the best available data we have on cost efficiency of these drugs. Right now, we do not even have, the databases to let us understand what is being prescribed for Canadians for the different conditions. This is one of the building block, one of the institutional capacity we need in order to have a more rational system, because I emphasize the issue of a lot of people lacking coverage. So we have under consumption of some drugs, absolutely. But a good universal pharmacare system, it's about making sure we have a rational system, a rational drug coverage, in order to tackle as well overconsumption of drugs, which is a huge issue, or inappropriate prescribing of drug. I mean, the opioid crisis, for example, is a good symptom how big this problem can become. We need to put in place these institutional capacities. And especially, in the last 10 years, what we've been seeing, all these new super expensive specialty drugs for rare disease, the current fragmented system is not equipped to tackle with these new, more complex drugs, and we need to build up the institutional capacities to deal with that. So universal pharmacare, it's not only about processing bill. Yes, it's about providing better coverage for everybody, but better means, yes, better access, but also tackling issues of overconsumption.
And so everything you just described and the way forward for actual universal pharmacare, I mean, just this fall in the House of Commons after the end of the supply and confidence agreement, a lot of political capital was spent just trying to put forward Bill C-64, an act respecting pharmacare. What is that exactly if that's not itself a universal pharmacare bill?
Well, like you said, it's part of this supply and confidence agreement. There was this deadline, they had to arrive with something. And let's just say that since 2020, since the beginning of the pandemic, the Liberals have been very reluctant on the pharmacare issue. Let's just say that for me, we've been groveling in front of drug companies in order, for example, to get access to vaccine procurement and things like that. All the more progressive legislations, regulations that were being put in place, we had universal pharmacare that was being put in place through the Hoskins report, the Hoskins Commission. That's one thing. The Liberal government committed at the time to embrace all the recommendations of the Hoskins report. Finally, 2020, they stopped doing anything about it. So we had to wait until supply and confidence agreement 2022. That's one thing. But you get other regulations, for example, on the price of patented drugs that was taken off the table. It's just the regulations were announced. It was supposed to be implemented starting July 2020. They postponed the implementation 5 times in a row, and finally they decided to take this off the table. So the problem is we ended up with a government not wanting to do anything that were going against the interest of the commercial interests of drug companies here. So C-64, basically part of the deal, but still, this is a bill that is very vague. That's one thing. Yes, we're setting up a Canadian drug agency, but what will be the governance? What will be on the board of this agency? For example, it's important if you fill this up with people from private insurance and drug companies, maybe not the best system in place. The bill says, okay, we need to have an agreement between the federal health minister and the provincial health minister in terms of what the universal pharmacare will look like for that province. And also, something super important, the Hoskins report was saying the first step for universal pharmacare, we need to start with a basket of essential medicines. So essential medicines, you have the WHO that has a list of essential medicines, something like 200 drugs that is covering more or less 2/3 the medical needs of the population. Normally, these are older drugs, cheaper drugs as well, easier to deal with. So Hoskins was saying, let's start with a basket of these essential medicines, basically that will be covering most of the medical needs of the population. And then on 5 years, let's build up a comprehensive formulary, basically a comprehensive list of all the drugs that will be covered. So we start with the easier, more important drugs, and then we build with the more complex, expensive drugs. Now, this is not what C-64 is doing. Basically, it's not a basket of essential medicines. We're focusing on only 2 types of drugs for diabetes and contraceptives, and that's it. And that's not enough. At the same time, we can understand the logic here. Okay, let's have a first step to test the concept of universal pharmacare, to put in place some of the institutional capacity needed. And in fact, everything is there in the bill. It's all a bit vague, so sometimes it's a bit ambivalent. But yes, they are creating a Canadian drug agency. Yes, we will have a national formulary. Yes, we do have a strategy for drugs for rare disease as well that will be coming. So we have different elements in there. It's all about the discourse, the narrative of universal pharmacare. Fantastic, but still, it's still vague and a bit ambivalent on some issues.
Yeah, vague and ambivalent. I mean, you allude here that C-64 is insufficient in terms of creating something like a universal pharmacare program, but you also in your paper, you also say that the bill may be deceitful by design. Could you tell us more about why there's more to it than meets the eye?
And going back to our definition of universal pharmacare. So pharmacare, it's a public drug plan. Universal based on the concept of universality in social policy. So a universal program, the same program applied to everybody. You read the bill, it's all the narrative of universal pharmacare. So it all looks good. Then, okay, how do they define pharmacare? Pharmacare is defined as a drug plan. any type of drug. Universal is defined in terms of as long as everybody is covered. I live in Quebec. In Quebec, we have mandatory private drug plans. So based on the definitions in the bill, then the Quebec system, which by the way is the most expensive system in all of Canada. So basically after the United States, the second place on earth where it is the most expensive per capita is Quebec. It's based on mandatory private drug plans. And that fits the definition of the bill. So for example, when the health minister was testifying at Senate, senators asked him, well, is your universal pharmacare program, will it be publicly administered? And his response was, well, I'm still ambivalent about this. Well, that's a huge issue. If we entrench a system of mandatory private drug plans, because keep in mind, what got me very concerned, you read the bill looks fine. Then some weeks after, we had the budget, the federal budget. And when it came to the implementation of that bill, the credits in the budget was absolutely not sufficient to cover the needs for both contraceptives and diabetes product for the whole Canadian population. So one of the assumptions was that private plans will still be covering these products, which is nonsense. If I am an employer, I'm providing private drug benefits to my employees, and some of these products can be provided for free through the public system. There's no reason I should still be paying for that. I should be using that money for something else, basically, in terms of the benefits I offer the employees. So if your assumption is that private drug plans will continue to cover these products, the only way you can achieve that in reality is to make the coverage of these products mandatory for these private plans. And this is what got me very concerned. Then the PBO, the Parliamentary Budget Officer, also did the costing for C64, arriving with the same result in terms of the cost, as if private plans would continue to cover the what they're covering at the moment for diabetes and contraceptives, which got me very concerned. So when we testified in Senate after the health minister, I say we because some academics with Steve Morgan, Matthew Herder as well, basically we've been emphasizing there's a problem. This bill is too vague, and it might be a fantastic step in the right direction, but it can also be used to entrench a completely irrational and inefficient system in place, with which we will be stuck for the next 20 years. Basically, the discussion will be ending on Pharmacare if we have this type of bill that is being put in place. So we're very concerned. We raised these concerns, asking for amendments by the Senate to make sure that the bill will not be used in a way that goes against what is universal pharmacare. Finally, the health minister sent a letter to the Senate saying, well, I wasn't clear enough last time. I just want to assure everybody that it will be a public administration of this national drug plan. So let's just say this type of letter, it's not as good as having this directly in the legislation, but let's just say that if it goes to court, this type of letter will have some weight, basically, so we can, let's say, the different groups that would not be happy with the mandatory private system could go to courts with that, and this type of letter will have some weight to make sure that, yes, what we're talking about is publicly administered universal pharmacare system for all Canadians. And what's important here, a lot of people interpret this as, oh, the bad government will be taking away the existing coverage. No, what the government will do will start covering stuff for all Canadians without taking anything away from current private drug plans. Employers can still continue to provide additional drug benefits if they want to. And you know what? Employers and employees, when doing collective bargaining and negotiating the collective agreement, now we'll have more funds, and we'll have to decide how will we use the savings we made, because now we have public coverage that exists for some of the products we were paying for. We're not taking nothing away from workers or employers. They will have to decide, workers and employers, in terms of how they will use the savings. Will they use this for additional health benefits of other sorts, or basically just let's increase the wages? You will have to decide.
It still does sound to me like you have to admit there are some advances made on Pharmacare, but even through all of that tough battle, the program still requires buy-in from provinces and territories where you describe there being a patchwork of programs. How tough do you think implementing this program will be considering, this current federal government's timeline? Do we risk losing these hard-fought gains, no matter how small they are or how big you might think they are they at risk?
Yes, absolutely. So at least we have a bill. So there's some obligations of the government to do something with that. But and like I said, if the current health minister now has clarified his position in terms of public administration, maybe the next health minister might not be as keen basically in implementing this type of system, even if the bill has passed. Basically, we need to have negotiations with the provinces. We need to have an agreement with the province. And if I can find thousands of reasons to delay negotiations on this issue with provinces. The feet dragging approach might be something we can see with another government, for example. That being said, for me, there's a lot of pros and cons. There's some vagueness on the governance of the drug agency, for example, not enough drug covered. But still, it's an interesting test. And in this way, it's an interesting first step that is designed also to build the institutional capacity for a real universal pharmacare system. We're still far from a real universal pharmacare system. Now we pick two types of drugs, diabetes. By the way, diabetes, I think it's great because the socioeconomic disparities in terms of access to diabetes drugs is absolutely awful right now. 10 years ago, there was a fantastic study looking only in Ontario. In Ontario, you get comprehensive coverage once you arrive at 65, but not when you're 64. So basically, they're looking at the discrepancy in terms of access. So in terms of morbidity and mortality due to diabetes for people 64 versus 65. And basically, you're much better off when you arrive at 65 than 64, because now you still have lots of issues of not having access to the drugs you need or to all the drugs you need, basically, which normally, which can complicate treatments. So by extrapolating, basically, they ended up with an estimate of 700 people a year in Ontario alone were dying of diabetes because of financial barriers to these products. 700 people, this is the equivalent of 2 jumbo jets every year crashing down downtown Ottawa. But let's just say it's way less spectacular than jumbo jets. These are people dying on hospital beds, and they become part of statistics. And lots of people basically don't care about this because it doesn't make the headlines. But this is huge in terms of impact. So diabetes, great. Contraceptives, there's way more of a political statement here. It's just, okay, in terms of sexual and reproductive health and rights, we want to make a political statement, make sure that all women have access to the contraceptives they need. That can make a bit of a feminist critique here. It's just, why is it only the contraceptives for women? Why aren't condoms part of what is being covered, for example? But still, this is a great step forward on this specific issue of sexual and reproductive health and rights. That being said, the federal government is just mimicking the type of coverage that is happening right now in BC, which is the most comprehensive coverage for contraceptives, and wants to expand this to the rest of Canada. We understand the logic. Now, we did have one agreement between the federal government and the BC government in terms of implementing Pharmacare. But the thing is, BC is already covering contraceptives. So the federal government said, well, instead of contraceptives, let's cover instead hormone replacement therapy for women with the premenopause. The thing is, yes, you need to cover HRT, but don't start picking the type of disease or treatment you'll be covering based on the electoral gains you might be able to do in the next election. This is not what the Universal Pharmacare Plan is about. The managing of the national formulary must be based on cost efficiency, must be based by comparing treatments, must be based in a way that you can maximize the therapeutic value you will be getting for every dollar you spend. And I'm not saying we need to put a price on life here. That's not the point. It's just we have a budget in terms of what we're spending on drugs. Well, let's make sure that we're spending this budget in the best possible way to have the greatest therapeutic value for that specific budget. And if you end up with politicians deciding what will be on the national formulary versus what will not be on, this is not good policy, basically. But at least we already have one deal here. So system is not perfect, but it's going forward. Now we have a deal with one province, which is great. If they implement this before the next election, then we have a bit of a model for other provinces. We can look at what's going on, what's happening, and we can decide from that is just, do we want this in our province? I mean, I'm in Quebec. Quebec is always very reluctant to have the federal government in its jurisdictions and blah, blah, blah. Absolutely. But let's just say that if women in other provinces are getting contraceptives for free, and this is not the case in Quebec, that will be putting a lot of political pressure in terms of why do you refuse to provide this coverage for all women in Quebec when you can do this for free with the help of the federal government, basically. So let's just say that if we can have 1, 2, 3 provinces going forward with an agreement on these drugs, then it becomes a model for other provinces for them to be able to follow them.
It does sound like a tough situation, but what exactly is to be done then to achieve a truly universal pharmacare program across Canada?
So let's take out the across Canada 1 second. Living in Quebec, I still don't understand it. It would be so easy for Quebec to go forward with its own universal pharmacare system for the whole province. So get rid of mandatory private coverage, have mandatory social insurance, for example. So everybody will have mandatory public coverage. You pay some social insurance premiums. Basically, right now, the private premiums are taken out automatically from your wage. It would be the same thing with the social insurance premiums. The only difference, the social insurance premiums will be lower than the current private premiums. So there's no barriers for this. You can have, I mean, Saskatchewan was the first to go forward with universal healthcare. It would be great to have one province going forward with universal pharmacare. Ontario tried that under the Liberals. Basically, they said, let's go for the first step. Right now, the budget allows us to cover only for people 25 and under. So that was in 2018. Then the Ford government said, well, let's roll back the universal pharmacare. Let's make mandatory private coverage when it's available, and we'll just fill the gaps for everybody else who cannot, under 25, who cannot have access to a private plan. But let's just say some provinces have the capacity to do this by themselves. The problem is, right now, I think we need the federal government. Pharmacare system, the main objective should be to have the best access possible, rational prescribing habits, tackling both underconsumption and overconsumption, and making sure everybody have access to the drugs they need at the lowest cost possible. This is what Pharmacare is about.
Where can people find more of your work?
I have a research project on what we call ghost management. So for both the pharmaceutical sector and the chemical sector, so looking at the behind the scenes corporate strategies, both in pharmaceuticals and with chemicals. www.carleton.ca/ghost management in one word. And what I did there is that everything I published as well on Pharmacare, I included this on the website. So you go in the resources for that website. Otherwise, I strongly suggest people to read the latest issue of Perspective. Basically, we explain this in details. Keep in mind, there's a lot of noise, of stuff that is being said on Pharmacare that is just nonsense. There's a lot of money involved when it comes to prescription drugs. So there's a lot of lobbies. We can save billions of dollars a year. We can save up to $10 billion a year on a bill that is right now $40 billion a year. So the problem is that every dollar you can save is a dollar of income that somebody else will not be getting, and that somebody else will do everything they can basically to obtain this. So what we're seeing is that you have some lobby groups. The Fraser Institute is one of them. The Canadian Health Policy Institute, basically, which is an extension of the Fraser Institute. Institut économique de Montréal. But the conference board is complete nonsense what they've been publishing on Pharmacare in recent years. Sometimes conference board have some very interesting studies with solid methods. On Pharmacare, basically, that was complete crap. I had some of my ex-students, basically, that resigned the conference board because of these Pharmacare reports, saying this is unacceptable, basically, that we're doing this. What we see as well, now we have organizations like CARP, for example, the Canadian Association of Retired People, that is only, saying, oh, well, we need to be careful on Pharmacare, and just quoting Fraser Institute, Canadian Health Policy Institute, Institut économique de Montréal, and Conference Board. What I try to do in the paper for perspective, basically, the references, I think there's 5 pages of references. It's only the scientific literature. So not the petty debate with the lobby groups. It's really what is the scientific literature saying about healthcare coverage, what needs to be done. So in terms of resource, that would be the first one. And then I fell in love with the Hoskins report in 2019. At first, I wasn't very happy with that. I thought it was going too slowly, etc. But in terms of a timeline for implementation, a very prudent way to meeting the least resistance to do things well, I think it's a little gem. I think in terms of the implementation strategy, this is absolutely great. Just go see the executive summary. This is like 10 pages, and that synthesizes very well what needs to be done based on the best available evidence, not basically narratives of think tanks.
We'll be sure to link all of those items in our show notes. Marc-André Gagnon, thank you for joining me on the Perspectives Journal podcast.
Clement, was my real pleasure.
That was Marc-André Gagnon, Associate Professor at Carleton University School of Public Policy and Administration, and author of Pharmacare and Access to Medicines in Canada, Is Bill 64 a Step in the Right Direction?, which you can now read in Perspectives Journal number 2 in print and online. And if you like this episode, share and subscribe to Perspectives, a Canadian journal of political economy and social democracy, on all major podcast platforms, as well as Press Progress's Sources podcast, that digs deeper into the news stories you won't find in the major papers. The Perspectives Journal podcast and Sources are proud members of the Harbinger Media Network, Canada's progressive podcast community. You can read more in Perspectives, a publication of the Broadbent Institute, by visiting perspectivesjournal.ca.